Hi, Mike Gibson, Stefan James coming to you live from ESC 2024. We're talking about the SWEDEGRAFT trial. Stefan, talk to us a little bit about the hypothesis, the question, and how you answered it.
Yeah, so it's an important question to investigate the survival of vein graft because those are important for the long-term outcomes of patients undergoing CABG. And so we wanted to investigate the long-term vein graft patency in patients undergoing no-touch vein grafts harvesting versus the traditional way of harvesting these vein grafts. This was something that was invented and developed in Sweden, so it's particularly important for us in Sweden and Denmark to try to evaluate in the sufficiently large trial and look at both the clinical benefit in terms of vein grafts performance, clinical events, and side effects. So that's what we wanted to do. So we randomized 900 patients to receive either the traditional open vein graft harvesting or the no-touch vein graft harvesting and handling of the vein grafts.
Tell us a little more technically about the no-touch approach.
Yeah, so that was developed here in a hospital in Örebro, Sweden, with the hypothesis if you take not only the vein and strip it and ligate all the side branches and you keep the surrounding tissue, you will have a more viable graft. You will, it will more nerves, more microvessels will grow in. That will prolong the function of the vein graft and reduce the risk of vein graft failure. That was the hypothesis, and they have proven that in a number of small to medium-sized studies. So that has shown to be prolonging the durability of these graft, and that has actually been accepted in the guideline committees, both in Europe and in the US. So that's in Europe it's a 2B recommendation or 2A recommendation.
And so what did you find?
And so we randomized 900 patients and we had CTA as part of the primary endpoint, which was meant to study the survival of the vein grafts. So the primary endpoint was planned to be evaluated at about 2 years. We wanted it to be fairly long. Now, due to COVID, that happened to be almost 3 years instead of 2 years. But we were able to have a CTA in about 80% of the patients, which we think is reasonably good after almost 3 years. And so the primary endpoint was either a vein graft stenosis of at least 50%, or if patients had had a PCI on the vein graft, or in the native vessel proximal to the distal anastomosis of the vein graft, or if they had died. So that triple composite was the primary endpoint, and we found no significant difference between these two groups. There was a numerically lower event rate in the no-touch graft as compared to the standard technique. So that pointed in the direction of the previous studies, but it was far from statistically significant. We also looked at clinical events, which was an important secondary endpoint, and that was after almost 4 years. And that was a more traditional clinical endpoint, death, myocardial infarction, or any revascularization. And that was not significant, and it was actually numerically in the other direction, slightly in favor of the traditional vein grafts. Then we looked importantly at vein graft complications, leg complications, wound complications, and that we did by calling the patients at 2 occasions, once early and one late. So 3 months and 2 years. And in the first occasion, there were more infections, there were more symptoms, there were more hospital visits, reoperations, and up to 2 years, there were more symptoms, more loss of sensitivity, pain, swollenness. So patients did feel worse up to 2 years. So I think the combination
in the no-touch arm or
in the no-touch, yeah, because that creates larger wounds.
Yeah.
So there's a healing issue.
Yeah. Wow. Well, another hypothesis shot down by the data. Is this enough to change the guidelines, Stefan?
No, it has to be put in perspectives, of course. There was a Chinese trial published a couple of years ago. That wasn't performed when we started, but it was published before us. It was slightly larger. They had a phenomenal follow-up, maybe too good to be true, and 96% CTA, but a shorter duration of follow-up, 1 year. They showed a significant benefit for the primary endpoint, which was similar, was related to stenosis, but they also found less angina pectoris.
Hmm.
But of course, these are open label trials for obvious reasons. So that reduction in angina has to be taken with some consideration. They didn't follow wound complications as thoroughly as we did. And so I think with all this information together, I think also our study perhaps points in a numerical direction of the veins fare a little bit better, perhaps, but it doesn't translate into clinical benefit of patients, not for hard clinical endpoints, and they have much more, fairly serious complications. So I think personally that this cannot be recommended as a standard procedure in CABG.
Well, this is why we do randomized trials, right, Stefan? You ask an honest question, you get an honest answer, and this is how we practice.
Yeah,
Congratulations to you and your group, Stefan. This is great work. Thank you.
thank you.
And thanks to all of you for joining us here live from ESC 2024.
Thank you very much, Mike.